Hello everyone, my name is Jessica Waters and today I'll be walking you through the essential knee projections. So why the knee? As future radiologic technologists, mastering knee projections give us a solid foundation in positioning accuracy, central ray angulation, and image evaluation. These exams teach us how to see rotation, to judge alignment, and how to correct mistakes before they repeat themselves. And most importantly, they help us serve our patients with confidence, clarity, and care. I hope this presentation helps these projections feel clearer, more approachable, and more purposeful. So we're going to begin today with the AP knee. Our evaluation criteria for the AP knee is pretty straightforward. The entire knee is free of rotation, slight superimposition of the fibular head of the tibia. The patella is completely superimposed over the femur. Open femorotibial joint space with interspace of equal width on both sides. So before we get started with the AP knee, it's very important to know whether or not we angle. And this depends on the as-is to tabletop measurement of our patient. By knowing this helps open the joint space correctly for each body habitus. So as you see over here, smaller patients that are smaller than 19 centimeters, our angle is going to be 3 to 5 Caldet. Our patients between 19 to 24 centimeters, we want a central ray that's perpendicular. And our patients that are larger than 24 centimeters, we do an angle of 3 to 5 degrees cephalad. So we start this projection with 40 inches SID, a central ray ½ inch below the patella apex. Collimation is a good 8 by 10. Patient position is supine, and leg extended with femoral condyles parallel to the IR. So here are some good images. We see that the patella is centered. We see that the fibula head is slightly superimposed by the tibia, and we have nice open joint spaces. In our not so good images, we see that the patella is angled, and it shows that these two images are too rotated. So moving on to lateral knee. Our evaluation criteria for the lateral knee is that the knee needs to be flexed 20 to 30 degrees. Femoral condyles are superimposed. Open patellofemoral joint space. Open head slightly superimposed on tibia. So to start this projection, we do an SID of 40. Our central ray is 5 to 7 degrees cephalad. And the reason we do this is because the medial femoral condyle sits lower than the lateral femoral condyle. And by using this angulation, it will make them superimpose. Also, our collimation is 8 by 10. We're going to position our patient in part by a recumbent on the affected side with the knee flexed 20 to 30 degrees so that patella is perpendicular to the IR. So here's a list of how to tell if a lateral knee is to or under rotated. To rotated, the anterior surface of the medial condyle moves closer to the patella, while under rotated, the anterior surface of the medial condyle moves further from the patella. So, of course, to rotated means it's rotated towards the IR. Under rotated means it's rotated away from the IR. With the to rotated, it's less superimposition of the fibular head and tibia. This is my favorite way of remembering it. While under rotated is more superimposition of the fibular head and tibia. So here's our good. We see that the femoral condyles are beautifully superimposed. We have a nice, beautiful open space of the patella joint. And here's a not so good. So our first image over here is under rotated. We see that fibula is to superimpose into the tibia, which means that's under rotated. In our second image, we see over here that it is over rotated because the fibula is almost completely separated from the tibia. So comparing, here you go. So moving on to AP oblique lateral rotation. So the evaluation criteria for the AP oblique lateral rotation is fibula is superimposed over the lateral half of the tibia. Patella margin projected slightly beyond the lateral femoral condyle. An open knee joint. So we'll start this projection with SID 40, central ray a ½ inch below the patella apex. Our collimation 8x10, and we're going to position the patient in supine with affected knee extended. The affected leg is rotated 45 degrees laterally. So here's our good images. We see that the patella is right over the fibula and that the fibula is nice and superimposed by the tibia. Just always remember, your fibula is always on the lateral side. So if you have that patella over on the side as the fibula, it's on the lateral. So here's the bad. Although the patellas seem to be somewhat in the right position, we look at the fibula, it's not superimposed by the tibia, which tells me that they are both under rotated and a little too closely resemble to an AP knee. So moving on to the AP oblique medial rotation. So our evaluation criteria for the AP oblique medial rotation is that the patella shifts toward the medial side. The medial structures are best demonstrated. Proximal tibio-fibular joint is open. Fibula not overlapping the tibia. That's a really important spot right there. You see where that yellow highlight is? We want that nice open space. So we start this projection with SID 40. Our central ray is a ½ inch below the patella apex. Collimation is a good 8x10. And we position our patient supine with the affected knee extended. And we rotated the affected leg 45 degrees medial. Condyles form a 45-degree angle with the IR. So here's our good images. We see that nice open space between the fibula and the tibia, and that little joint space right there. And we see that patella is swinged over to the medial side. And here's our bad images. So we don't have any open space on the tibia and fibula. Even though the patella looks like they're going toward the medial side, it's just not open enough space. And on the second one over here, it looks like the central ray was off. So it looks like it's more of a distal femur. So here's our AP weight bearing. So why do we perform the AP weight bearing? We perform this to show and compare spaces under natural weight. It helps detect early degenerative changes of joint spaces. Commonly arthritis is a common one, such as osteoarthritis. Accesses alignment of the femur, tibia, and patella in standing position. This image here is a great image I found of an arthritic patient. You see that there's no open space of the knee right there. So let's look at our evaluation criteria for the AP weight-bearing knees. Both knees demonstrated without rotation. Knee joint spaces centered to the exposure area. Open joint spaces to evaluate for degenerative changes. So to do this projection, SID is 40. Central ray is 1 inch below the level of the patella apices. Our collimation is 14 by 17. And we position the patient standing, weight evenly distributed, toes pointing straight ahead, knees slightly separated. So now we're moving into our intercondylar fossa projections. So our evaluation criteria for the intercondylar fossa is open intercondylar fossas. That's the main purpose of these. Posterior inferior surface of the femoral condyles demonstrated. Intercondylar emesis and knee joint space clearly visualized. No rotation shown by slight tibiofibular overlap. So to perform our first one, the PA axial Hombold method, we do an SID of 40. Our central ray is perpendicular to the long axis of the lower leg, entering the popliteal fossa and exiting the patellar apex. Collimation is an 8 by 10. We position the patient prone on the table or standing upright. Part position as the knee of interest is flexed 70 degrees from full extension. Lower leg position so the central ray is perpendicular to his long axis. Our next one is the PA axial Camp Coventry. Our SID is 40 inches. Central ray is perpendicular to the long axis of the lower leg. We angle 40 to 50 caudal, depending on the knee flexion, and entering popliteal fossa and exiting patellar apex. Collimation is 8 by 10. Patient position is prone on the table and the knee is flexed 40 to 50 degrees. And our next one is the PA axial Beauclair. It is a 40-inch SID. Our central ray is perpendicular to the long axis of the lower leg, entering the knee joint a ½ inch below the patellar apex. Collimation is a good 8 by 10. And we position the patient supine, with the knee flexed enough to place the long axis of the femur at 60 degrees angle to the long axis of the tibia. So here's a really good image. We see that it's really clear and we can really see that in the intercondylar fossa very clear like a tunnel. We see that the fibular head is just very slightly superimposed by the tibia. And here's a bad image. Because it looks like there's some rotation in the leg. Also, there's not a very clear view of that fossa. It could be more open, I believe. Also, maybe a little slightly too open on the collimation. It should be a little tighter. So now we're going into the PA patella. Evaluation criteria for the PA patella. The patella completely superimposed by the femur. No rotation. Proper collimation that focuses on the patella. So pretty straightforward. We want that patella right in the center. It looks very similar to an AP. And most clinics do an AP knee over a PA patella. So to perform this projection, we do an SID of 40. Our central ray is perpendicular to the mid-popliteal area exiting the patella. Collimation is 6 by 6. We want a nice tight collimation because we're just focusing on the patella, not the whole entire knee. Patient positioning is prone, and we place the patella parallel with the plane of the IR. So here's our good images. They're right there in the center. The patella is right there. The second image probably could have been collimated in a little tighter, but it's still overall a good image. The not so good images. So first one, we see that the patella is definitely not in the center. There's definitely rotation. This could be due to a trauma incident or injury, but for the sake of the presentation, it's not a good one. Our second image over here, it looks like the patella is definitely not centered. Probably could be rotated a little bit more medial to make it more in the center. Also, it's a little fuzzy. That could be because of movement. So here are some of our other patella views. First, we'll start with the evaluation criteria. The patella is in profile. Femoral condyles and intercondylar sulcus clearly demonstrated. Open patellofemoral articulation. Proper collimation. So we want nice tight collimation when we do this. We want that patella to really stick out, and we want that nice clean open joint space. So the first one is the Merchant view. SID is 6 foot is recommended to reduce magnification. The central ray is perpendicular to the IR with the knee flexed 40 degrees. We angled the central ray 30 caudag from the horizontal plane. Collimation is adjust radiation field to 2 inches about the patellar shadow and 1 inch on each side. So you want a nice, small, tight collimation. Patient position is supine with both knees at end of table. And the knee is flexed 40 to 45 degrees and IR placed perpendicular to the central ray and resting on the patient's shin. I attached a nice picture so you could get a visualization of what it's explaining here. And our next one is the Settegast method. It's an SID of 40, a central ray angle of 15 to 20 cephalad, and we direct the beam tangential to the patellofemoral joint space. Collimation is nice and tight at 4x4. Patient position is prone or supine. Part positioning is flex the knee slowly until the patella is perpendicular to the IR. Ensure that the IR is centered to the patellofemoral joint space. So here's our good one. We see that patella is nice and good in profile, and we see that nice open space. And here's our bad ones. You see that there's not really much open space of the joints. The images are not very clear. It could be due to lack of angulation. Maybe some technique factors are involved in here. I think that very first one might have to do to some pathology, as it looks like there's some ridges on the top of the patella. So that could be pathology related. All right, so here's my ARRT questions. My first one is, when performing an AP knee, the degree and direction of the central ray angulation depends on which of the following patient measurements. So the correct answer is C. It depends on the as is to table distance. Question number 2. A properly positioned lateral knee will demonstrate which of the following. Correct answer is C. Superimposed femoral condyles. And my third and final question. The primary reason for performing an AP weight-bearing knee projection is to evaluate correct answer is D. Early degenerative arthritis. The compression exposes narrowing of the joint more clearly and shows arthritis. As you see, this first image is an arthritic patient, while my second image is a healthy patient. All right, well, thank y'all for listening to my presentation. I hope you learned something from this. Here are my references for all the images I used, and I hope y'all have a great day. Thank you.